Good afternoon, everybody. Thank you for joining for the SEEK Wave 5 Action Period Call number 5. We are making our way through the program. I appreciate all of you being here. We will always want to thank our program partner, Ohio Department of Health, Violence and Injury Prevention Section, or VIPS. And a disclaimer from ODH is here. And just a plug for the Ohio AAP Spring Education Meeting. It's coming up not this Friday, but the next Friday, 19th. We will be in Dublin for this. We have really good topics and speakers and educational sessions on tap for next Friday the 19th. So you can go to ohioaap.org/spring meeting for more information on our spring education meeting, or you can reach out to me and I can help you out. And we are still giving out our lead poisoning prevention books. These are available to you for free. The link to receive more information on those is ohioaap.org/leadbooks, or you can reach out to me. So for the agenda for today, I want to welcome all of you, and then we will hear our aggregate data review from Zainab, and then we will hear from Lisa DeGeeter from the Ohio Domestic Violence Network. Lisa, happy to have you. So welcome all of you. If you can do so safely, please share in the chat your name and your practice. And anyone who was on maybe a device that doesn't have a clear username, if you could put in the chat that you are here, I'd appreciate it. And then how did you watch the clips? How did you spend the amazing time on Monday? I'm just curious. And Zainab, I have your slides when you're ready.
Thank you. I'm ready. So I wanted to first of all thank everybody that's been submitting their data. We really do appreciate it. You know, these slides are aggregate slides, but you do also receive your practice level slides. So the data is just for your practice. Again, I haven't heard any questions. I'm sure, Brooke, you haven't either, about any of the data. But if anything does come off or does pop off as a little bit weird, which it shouldn't, especially for like the QI period. If you have any questions or anything like that, or you want to go through your data alone, we can definitely do that. But again, thank you so much for taking the time for submitting that data and for doing so in a timely manner. So as you know, our screening tool asks about four umbrella topics and a fifth one just for the younger age group. So here you can see this the graphs divided by the birth to 12 months, the younger age group, and then the 13-month to 5-year, the older age group. And those are with the blue and the orange lines. But as you can see, for social needs, especially after QI, so you can see here in the x-axis where we have the division of the QI months, there was a significant increase, and we're still seeing those consistently stay at 100%, especially for social needs. And that includes questions like whether or not the caregiver needs help finding a job or a daycare or something like that. So those are social needs. Again, the practices are doing very good here. In family needs, these are questions about the moms or the caregivers' mental health, if they're struggling with depression and things like that. So those are the family needs. We are seeing 100% in terms of those that are screened. So those that do receive the screening tool are completing all of the family needs questions. And that's for the screening. The counseled of those that indicate that there's a need, of those that say, oh yeah, I do need help, or yeah, I am struggling with my mental health. How many of those are counseled? There was a slight dip in March for both age groups. But we're still at a good point where we can get that number back up to close to 100%, just like we're seeing with social needs. Again, just as a reminder, there are resources for family needs in our resource sheet that we provide. So if you provide that to the family or if you provide them with other written resources in which they can find help, that's also considered counseling. So it does not need to be a verbal conversation with the family unless, time permits or you feel like it's necessary. Next slide, please. And home safety. So home safety is where the largest chunk of the questions in the survey or the injury prevention part of the survey it has the largest chunk of questions within the home safety. So these include questions like whether or not the caregiver is CPR trained, if you have the number for poison control, if the furniture is secured to the wall, if there are like choking hazards for the child. Um, Usually there's a lot of needs in this topic. Um, so again, as I mentioned, we do have resources in the resource sheet for these things, but it's been a little bit more difficult to try and get that to 100% in terms of counseling. And so we understand that it could be a little bit difficult, but for example, if the family indicates that they don't have CPR training, if you provide them with the resource sheet and if you give them ways in which they can get that training, then technically that's them being counseled. Again, we are seeing some dips in March. If any of the practices are struggling or they feel like something's going on, please let us know so that we can keep in mind, um, as we continue through the QI months. But yes, we do see a little bit of a dip, but we're hoping again to bring that up to where it was around December, in the beginning of the QI, in the beginning of the project. Next slide, please. And then car seat safety. So again, this question is asked to both the older age group and the younger age group. We do see a little bit of some fluctuations um, in terms of the counseling. Everyone's being asked these questions in the survey, but the older age group, I think that was like 4 out of 7. So that's also something to keep in mind. I can include those values here. Um, so the numerator and the denominator, where these percentages are coming from. We are seeing a dip in the older age group in terms of counseling for car seat safety, but that's because a small number of families had a need in the first place. So 4 out of the 7 were counseled, so that's why we're seeing that slight dip there. Um, but yeah, just to keep in mind that we do also provide, and correct me if I'm wrong, Brooke, we do also provide some resources on car seat safety. Um, so again, if they're receiving that resource sheet, please consider them as counseled. They can find the resources that they need there, or if they have questions about that, I'm sure there's a number or a QR code on there that they could also use. The final topic is safe sleep. This question is only asked of the younger age group, so you can see there's only one line here. Again, in terms of screening, 100% of those that are receiving the screening tool are filling out this portion of the survey of the screening tool. In terms of counseling, we are seeing again a little bit of a dip in March um, compared to December through February. It's not very significant. I still feel like there's hope for us to get back to where we were. So we're hoping to see that number increase possibly. But um, but yeah, these numbers are just to show you how the practices in total are doing, and you can compare your data if you would like to these aggregate slides just to see where you fall in terms of what the average looks like. So if you're performing better or if you're performing a little bit less than what the aggregate is showing, that's just information for you to either, you know, be super proud of your work. And again, even if you're not performing as good as the average, that's still an opportunity to be proud of yourself. But um, it gives you some sort of idea of where you could improve if you can improve. Um, Next slide, please. And this is the resources provided. Again, this is the resource sheet that we're providing to the households or to the families. Next slide, please. This is the screening tool completion rate again. So this kind of goes hand in hand with the screening rate that you're seeing on the left side of the slides that we were just looking at. 100% of those that are receiving the screening tool are completing the majority of it or completing 100% of it. Next slide, please. And here, this is the other part of the survey, the family feedback survey. or how the family reacts to what happened. So they indicated a need. They had a conversation with the primary care physician. Do they plan to make a change? The majority do plan to make a change. We're hovering at over 90% since the beginning of QI in terms of those that are planning to change. On only less than 10% are saying that they do not plan to change any of what's going on to improve their needs. Next slide, please. The likelihood of change. This is almost like a Likert scale, ready to make a change, seriously considering changing, thinking about changing, or no thought of changing. As you can see, in March, we are seeing equal numbers of those that are saying seriously considering changing and thinking about changing. Those are a lot higher than what we saw in January and February. Again, this is up to the family and whether or not they're willing to make that change. But we're seeing very minimal people say that they're not willing to change at all or have no thought of changing. Next slide, please. Or I think that, and then families willing to implement a behavior change. So we want to know, of those that received the resources and of those that had the counseling, how many of them are willing to make a change? How many of them are willing to change their behavior? And again, we're hovering at about 95%, and even higher in previous months. So that just gives you an idea that the work that you're doing, the resources that you're providing, are really helping these families. They're willing to make a change. They're willing to implement new things to decrease their needs. So this is just kudos to you and to the work that you're doing. And this is just to show you what the families are saying from the help that they've received from you. And if anyone has questions, please either put them in the chat or go ahead and come off mute and ask. If nothing comes up now, but something comes up later, please either let me or Brooke know, or let Brooke know and she'll forward that question to me again. You'll receive your individual level data by next week. And if any questions do come up about that, then again, also please let us know.
Zainab, thank you. I echo your thoughts on we have time to get those metrics back up. I know that on the practice coaching calls, we've had some good conversations about the reality of things that are happening within the practices and kind of maybe the lower numbers going into spring that people are seeing. So all of those things are factored in, and I appreciate you identifying those trends for us. And the practices and I having good conversations about that. But again, questions for Zainab, when you get the data next week, I can liaise those to her and can always talk to you about any additional things around the program. Thanks, Zainab.
Thank you.
Okay, Lisa, you are up next. We are hearing from Lisa DeGeeter from the Ohio Domestic Violence Network. She is new to our SEEK educational panel, which we appreciated. We connected in some other good work that we are doing around this important topic. But Lisa, I want to welcome you to the SEEK program.
Thank you so much. And I'm very glad to be here and to have heard what I just heard, because it's marvelous to see that everything is framed in terms of safety, because the work we do and the way we tend to frame things follows that mold. And I'm very glad we made the connection, because I think it's a good fit, because we have to respect people and what they're willing to do and in terms of changes, and the decisions they make and what they have the capacity to do. We see very similar things in the DV field. So I think this is going to line up really, really well. So you've got my name and information. And if you can go to the next slide, just give you some overview, let folks know what we're going to talk about today. Want to talk a little bit about what domestic violence is and isn't, and how to see it and how to work with survivors, explain a little about what ODVN does, share some of the resources that we have, and share one of the other websites that we are responsible for, which is called Ohio Heals, which deals with children specifically, since this is a pediatric group. Talk about, since this is the VIPS section of ODH, look at some of the work we do around prevention. I specifically do a fair amount of work about policy, so I'll just give you a little bit of what that looks like and give you some ways to plug into ODVN resources, because it looks like you're in communities around the state, and I know it's going to be recorded, so that broadens it. And we're not always the place to go. We are a membership organization. So we have 76 programs, either shelters or non-residential programs around the state, and plugging into those local resources are usually a good bet. So if we want to hop up, actually probably 2 slides, because that's what we'll start with, is DV 101. And this, I think the portions fly into. So give it a couple clicks. So when we talk about DV, we want to talk about different things. People traditionally, you've seen the posters where somebody has a black eye, those kind of battered woman kind of images. But we want to be really, really clear that DV does certainly include physical and sexual assaults, that those injuries do happen. We're absolutely in our program seeing those things, but really it starts with a pattern of coercive control, of behaviors where somebody's exerting an undue level of influence over their partner to control their behavior. One of the folks I work with at ODVN, who does a lot of work with previously incarcerated survivors who have killed their abuser and are now getting out of, either seeking clemency or out of prison and working to reintegrate into society, she tells a story of a woman that she worked with who was couple dated, everything was fine, got married, beautiful honeymoon, all this wonderful stuff. But very, very early in the marriage, she did something he was not happy with. And he, excuse the phrase, but beat her to a pulp. So the black eyes, the split lips, the bruises, bleeding, injuries. And he not only beat her, he took photos of her face to show the damage that he caused. He waited a couple of days so that things were bruised and swollen. And he took them, and this is an old story, so he had the photos developed because it wasn't digital, and he got an 8x10 made of her, close-up of her face, swollen and black and blue, and he framed it. And he put it on a table in their front hall so that anytime she came in or out, she went past this image of herself pounded. And it was one of these tables that had a drawer. So anytime anybody came over, the picture was just slid into the drawer. But anytime she said or did anything after that he didn't like, all he did was point to the picture. He didn't have to hit her a second time. He'd established the level of control he needed with just one beating, and a way to remind her of it. So I think sometimes it's that level of control, that level of coercion, the psychological abuse, and the feeling that victims can't escape, that people have a hard time wrapping their head around. So one of the resources I want to share, if anybody's taking notes, and I can send these to Brooke afterward, because a part of the reason I put the PowerPoint together the way I did is so that people have content they can go back to, and I can send you a few more links. But BWJP, the Battered Women's Justice Project, bwjp.org, and I can throw that when I'm done talking in the chat so that people have links to all of it. They've got some really good resources on both coercive control and on the impacts of domestic violence on children that I think folks could find useful. So if we pop up the last box here, it talks about how this is used against intimate partners. So that's the other component of DV that gets complicated. We originally talked about folks who are married, but we now know that about half of all births in Ohio are out of wedlock births. So people who have children in common, people who live together, people who have lived together in the past. There's a lot of different ways to form a relationship that makes it qualify as domestic violence, as people who could seek services from our programs. So if we go forward one more slide, I just wanted to, and my guess is that you've all seen some version of the power and control wheel about the kind of tactics and things that batterers do to maintain that control over their victims. So a lot of, I'm going to start at the bottom, isolating people who, if you ask them who they can go to if they have an issue, They don't talk to their parents anymore. They don't talk to siblings anymore. They're not allowed. And they use that kind of language. They're not permitted to speak to neighbors because isolation is a very powerful tool to keep people from seeking the help they need. And it allows you to normalize behavior that isn't normal. So denying, minimizing, taking advantage of using the kids. If you do this, I will get divorced and I'll take the kids from you. And that's a very powerful threat to folks in this situation because, and most of you have probably had training around trauma. I'm going to guess you can't do SEEK without some base trauma training. But we know that people who have been in traumatic experiences don't necessarily present well. We know that folks who've been traumatized don't tell narrative stories in a linear fashion. So when you go into court, you have somebody who looks discombobulated, who has issues, who can't explain themselves, versus a batterer who tends, if you're all about control, to present very well and be very organized. Batterers, when they seek sole custody, get it about 2/3 of the time. So saying, I will take the kids from you is a very real threat. And anyone who has any experience in this field knows that it's possible to make that happen. And I apologize, my phone's blowing up. So I apologize if you're hearing that in the background. But all of these are different tactics. And like I said, I know as adult learners, people don't like to be read to, and I don't want to read to you, but I wanted to make sure that the slides, if you wanted to go back to material, had some of this kind of information if you wanted to see it. So if we go to the next slide. Things that you can look for, because I know as you're talking and screening folks, it's that isolation. Do people have a support system? Are they canceling appointments and looking for why that happens? Because if somebody's not letting them use the car, or if somebody says, fine, you can have the keys, but there's no gas in it and I won't give you gas money. All of these are control tactics. Do partners check in? Are they there? Do they show up? Minimizing injuries and concerns, because if you're causing abuse and you're causing harm and you're causing injury, you know that you could get in trouble for that. So people downplay what it is they've done and sometimes play up issues that they can attribute to the parent who's being abused. And I'm going to guess that a lot of these things are exactly the kind of things that SEEK has already talked about in terms of looking at child abuse. When you see them in the parent, DV could very well be in the background. And you guys are scientists. So one of the things I want to tell you is that in between child abuse and domestic violence, when you read the studies, they say, depending upon what you're looking at, anywhere between 30% and 60% of families that are experiencing child abuse also have DV in the background. But that's an enormous range, 30% to 60%. And it goes back to this idea of, as we define DV, are you only looking at physical abuse? Are you looking at coercive control and other emotional kind of issues? Are you only looking at married families? Are you only looking at families with kids? So part of the reason you get such enormous ranges in some of the statistical information is that if you define it differently, you're looking at different pockets of things as they overlap. So I'm not a scientist. I'm a lawyer. I'm not as useful as you folks in terms of the number stuff. So I hope that makes some degree of sense, because it's not that some of these studies are invalid. It's when you frame the questions differently, you look at some very different pockets of numbers. But if we can go to the next slide. And I'm going to say, I know it's a small group, but if folks have questions, I am pretty informal. So please, if you've got a question at any point, I should have said this at the beginning, go ahead and pop in. But it's a fair amount of information to cover. So I'm trying to pop through so that we get to all of it in the time we have. So when we look specifically at the law, this is the section of code that defines domestic violence. Again, so this is why you see some different numbers. It has to be a family member. It has to be a household member. So if you have a child in common, but you're not married and you've never lived together, it looks a little different. Actually, child in common has been eventually added to the statute for some pieces of things. It also can't be an accident. So that knowingly causing or attempting to cause physical harm can't be something that can be attributed to something accidental. So we watch batterers who are savvy evade responsibility because they claim that things were accidental and not intentional. But this is the definition that we work with when we're dealing with court systems. So there are people who are certainly in situations where they're being harmed, and they could seek relief from our programs. Our programs would be able to assist them. And when we look at things definitionally, they fit, but they might not be able to walk into a court system and request criminal charges be filed, or they might not be able, where this is really important, is getting orders of protection. If you don't fit within this definition of a family or household member that's in the statute, that's not an avenue that's open to you. So that's an important thing to know. So let's hop up to the next one and get to what really undergirds all of this. Oh, I've got the slides in a different order, but that's all right. We can keep going. I thought we were going to pop up the video next. But what we are is ODVN, the Ohio Domestic Violence Network, is every state has a federally designated DV coalition. So we do a lot of training and technical assistance with our member programs, do prevention work, and work on public policy. For example, one of the things that I was just talking to one of the state reps about this morning in an email, you are all probably, I'm going to assume, as pediatricians with a background or at least some degree of background in child abuse, you're familiar with SAFE exams, the sexual assault forensic examinations for children who've been sexually abused. And those are the same SAFE exams that if there's an adolescent or an adult rape victim, that they may provide with a rape kit in a hospital emergency room. There's a state funding mechanism to pay for those SAFE exams so that victims aren't victimized and then send a bill for the help that they need to recover from it. Right now, there is no parallel funding for DV forensic medical exams. And we know that 83% of the folks who are seeking shelter in our member programs have experienced strangulation to the point that they've blacked out, that they could be dealing with traumatic brain injuries as a result of strangulation events and head injuries from abusive head trauma. And yet there's no funding that if they sought emergency medical care would cover that care. So we are looking at ways to put a line item in to the state budget so that DV forensic exams could be funded the way sexual assault forensic exams are funded. And it would be similar tools, because if you know about the SAFE exams, particularly for the pediatric ones, the tool that frequently gets used, it used to be a colposcope, but now it's a Cortex Flow to do digital images and videos to document those exams. There are filters you can put on a Cortex Flow, and they can see bruises that can't be seen with the naked eye. And they're having an extraordinary amount of success in a couple of hospital systems using Cortex Flows to document injuries that wouldn't otherwise be seen. And cases, I actually was in a meeting at the Supreme Court with an appellate judge about a month ago who was dealing with an appeal where a big chunk of the evidence was what the forensic nurse was able to provide through the DV exam. So these are the kind of things we work through in terms of providing services to make sure that legislative policy is coherent and protects survivors, and that our programs get what they need to be able to provide services to survivors. So if we can pop ahead. All right, here's the video that I thought was next. This should be embedded and be able to play for you, hopefully. My guess is the sharing isn't optimized for video. It's a system, and it's a setting inside of Zoom to share audio.
Are you hearing it? If I unmute, can you hear mine? You want to try that?
Sure.
Okay. Sorry. Let's go.
That's coming through quite garbled. The audio on this is coming through quite garbled. And it's a little choppy, but what it is, I can explain the video and send the link. It is an all-state. They called it America's largest prison break. And what you see is there's rolled up dollars in tampon applicators hiding in the bathroom, someplace the better wouldn't necessarily go to look. And if you advance maybe towards the end of it, even though they're showing it as a jail cell, what she's actually in is in the home bathroom getting out. So we can send a link to this so people can watch it on their own. But she's trying to get her hands on money to get out of the house. And the reality is, and you guys, I know I'm preaching to the choir because you're doctors and you see people not do things because they can't afford to do things. And that bottom line, because the question we always get, and it's the worst question, is why doesn't she just leave or why does she stay? Because she doesn't have options. She can't afford to get out. So I'll send this link to you as well so that you can send it out to people to watch it, but we can hop up to the next one. That's fine. There we go. So the reality is we know that more than 90% of survivors are dealing with financial abuse issues. If they could, why doesn't she just leave? It's Maslow's hierarchy of need. If you don't know where you're gonna sleep at night, if you don't know if you can put a roof over your kids' heads, if you don't know where your next meal's coming from, it is extraordinary what people will tolerate so that they can meet those basic needs. And the vast majority of people who are walking into our member program services are people where the violence is so severe that's beyond, even if you don't know where your next meal is coming from, you've got to get out. So we're seeing people in some extraordinarily serious, dangerous situations to serve. And what we have seen since the pandemic is that the violence, we don't have statistics or numbers around it, but anecdotally, what we're seeing is violence that is more severe, more broken bones, more internal injuries, just people who are more seriously physically harmed before they leave. So we can pop to the next one. So the other issue is, why doesn't somebody just leave? They can't afford to. When they finally get to the point where they can leave or they have to, regardless, it doesn't end the abuse. Because the thought is if someone left, then the abuse would end. Oh no, there's still threats. We're seeing folks stalked. That's one of the bills we're working on, is dealing with stalking. And AirTags, Apple AirTags or other Tiles devices like that being put in purses or diaper bags or attached to cars. Stalking is what attorneys refer to, what prosecutors refer to as a pattern offense. You can't be stalked once. You're just in the same place at the same time. Stalking is a pattern of behavior. And so if you have to show that it's occurred multiple times, it's evidential. In terms of evidence, it's much more complex for prosecutors to show. So there's currently a bill pending that we hope passes in this General Assembly that will make actually attaching an AirTag or an Tile or any of those kind of devices to someone without their knowledge a crime in and of itself, regardless of how long it's there, regardless of whether somebody shows up. Just the act of installing the surveillance device will be criminalized. You can't do that to somebody without their knowledge. And that includes putting apps on phones and apps on tablets and apps on laptops to track people's movements. So we know the abuse continues, the financial control continues, and we see that in child support, we see that in child custody. My partner in crime here in the office and I are currently working with child support. We watch so many survivors not seek child support that their child is entitled to because of the concern that their address, their location will be shared with someone who said, I don't care if you leave me, I'll come back and find you and kill you if you leave me. And so they don't work with government systems that have the potential to share their address with their abuser. So all of these kind of things, it seems like it's simple. Why doesn't she just leave? But the abuse does not end, and they don't accomplish what they want to accomplish with leaving. And survivors know this. So they stay where they can manage what's going on. You know, it's one of those keep your friends close and your enemies closer. That can, for some folks, decrease danger. So let's go to the next slide. And since you're doctors, I wanted to pull in a little bit about the medical impacts. So, and all of this goes back to the notion of trauma. People who are jumpy, flashbacks, detached, don't seem to be focusing on the appropriate things. That anything that you've learned about signs of trauma in children is true for adults as well. Trauma survivors are trauma survivors. And you'll definitely see things developmentally that are different with kiddos. But bottom line is, if someone's being abused, that trauma, these kind of reactions, these are consistent things that you will see. If you wonder why they don't listen to something you're saying, trust becomes a huge issue. It becomes a question of, if you tell somebody this is how the response is going to be. So you learn that you don't tell people those things, because there's going to be consequences you can't manage. And I think I mentioned before that the inability to tell a linear story, if you've ever worked with sexually abused children, or if you work with the CACs in your community, trauma narratives aren't linear. You know, it's not Joe Friday. It's not just the facts. You don't get from point A to point B. Trauma memory tends to be very sensory. So whatever was seen or heard or smelt or tasted during an assault is going to be what's prominent and talked about, regardless of what the timeline of the events was. So if you see someone who's having a hard time explaining what has happened to them or what has happened with their child, considering what the traumatic event may have been in the background, even if they haven't explained it in that way, can be helpful as you chat with folks. So how about we hop up one more? The impact of abuse, when we look at it, we know, much like there's not quite a study the way ACEs, the adverse childhood experiences, lines up with different types of abuse experiences and long-term poor health outcomes for child abuse and children who've had adverse childhood experiences, but we do know that there's very similar. Folks who've experienced domestic violence, stroke, heart attack, asthma, substance use, and misuse are all things we absolutely see in this population as well. Again, and it goes back to trauma is trauma, and those kind of impacts matter. So let's hop up to the next one. So I'm giving you all the bad news, and I'm trying to front load it that way so I can tell you the good stuff at the end. So how do we work with folks? One of the really critically important things, it seems like a throwaway kind of phrase, survivors are experts on their lives. But that is so critical to the way we frame the work that we do. People know what they need. And one of the things I'm going to send you is a clip. It's called The Washing Machine. But it's about an advocate who sits down and talks to a survivor and says, what do you need? And the survivor says, really need a washing machine. And that's not really, we're not in the washing machine business, where we do support groups and we do protection orders and we help people with court cases and help them find apartments and help them with job skill training and help them safety plan around things. There's lots of things that we do. And finding washing machines is not on that list. But sometimes what somebody needs to solve a problem, and the video, and I won't go into it in detail, it's only a couple minutes long, but it talks about why having the machine having a machine herself would stop her from having to go to a laundromat, take kids out late, go past where the batterer's family lives, all of these kind of things. And it really solves a host of other problems. And I don't tell you this and suggest this video because I think you need to figure out how to get your clients washing machines or fix their cars or whatever other need they may come to you with, but to let you know that referring clients, if they need it, if it's appropriate, if they're disclosing domestic violence to you, to your local DV program, the advocates there do safety planning and orders of protection and all the things. but they also have an understanding that when somebody comes in and says, having this, getting my car fixed, getting a washing machine, getting whatever it is, figuring out how I can get into a childcare waiver program, whatever it might be, our advocates understand that that may be what is the first domino that starts lots of other things falling into place. So making those referrals to our programs sometimes may seem like an odd thing, but we're experts in the odd things too. So we can work on that, and that's a perfectly appropriate thing to do. But things to think about because you're pediatricians. I'm gonna guess you're usually in an office with a kiddo and a parent. And there are a lot of things parents, particularly survivors, are not going to disclose in front of the child. Things they don't want them to hear, details that might not be appropriate for them to know. So if there are ways, and I realize your staff are not supposed to be providing childcare, but if there is a way for a couple of minutes to have a conversation with an adult, if you've got a concern separate from a child, that can turn a conversation around to 180 because they can't have little ears here. Another thing that's very important, because you could end, and I realize nobody goes to med school because you want attorneys to subpoena you and call you in court. But you know, when you're dealing with child abuse and with domestic violence, that lots of different types of court, juvenile court, criminal court, both muni and common pleas and domestic relations courts, all places you might end up. And so it's critically important when you document things that it's about what you saw. I teach also guardian litums for the state Supreme Court. And we tell them constantly, you can't tell somebody this, you can't tell a judge somebody was dirty. Dirty doesn't tell them anything. What did you actually see? What was out of line in the home? What does disheveled mean? What does disheveled look like? Explain what is wrong. But there were a ton of dishes, and GAL is going to people's homes. So there's a ton of dishes in the sink and a pile of laundry next to a washing machine. That doesn't paint a picture of something crazy. Dirty dishes do go in the sink before they get washed, and people do pile laundry next to, if it's in the process, that's not necessarily a problem. People really need to know, particularly if you're going into a court situation, what it was that was out of place or wrong about things. The other thing to know that's different when working with adult survivors of any kind of victimization versus children, you guys are mandated reporters as medical professionals. We don't let people abuse children, and that's as it should be. That's a good thing. We don't let anybody, children or their parents, decide it's okay for this kid to be abused in that way. Short answer, no, it's not. Child abuse is a bad thing, and we try and stop it. And this is going to sound really strange, but abuse with adults is different. We let grown-ups, for better or for worse, make decisions about what they're willing to report and to whom. So we don't, when we approach our work, force people to answer specific ways or even answer all questions. So the fact that you've got screenings and people are answering, that to me is phenomenal. The fact that you've got people contemplating change from a motivational interviewing standpoint, that's fantastic. The responses you're getting sound awesome. But I wouldn't worry if things aren't 100%, because grown-ups get to make choices about what they do and don't disclose and who they disclose it to, and that's about reporting, making sure they know about your mandatory reporting obligations. They may not choose to share things because they may have an understanding of the other systems that start to get involved and the consequences that stem from that. And they know what risk they can manage. And sometimes, we talk about, oh, they lied. Yeah, it's a lie by omission, but sometimes people don't share things because they have an understanding of what comes next. And they're not ready for what comes next, and they know that. And we let adults make decisions like that for themselves. So yeah, all of that kind of stuff. And like I said, I put things on the slide so that people can have them to refer back to if it's helpful. But let's pop to the next one. So we don't want, I apologize, my computer's got things popping up on me here. So we don't want it's very easy to say, oh, I understand. Has anybody ever calmed down when somebody says, oh, calm down? You know, so this is kind of a standard list of, oh, relax, it'll be fine. We don't know that. So, and try to be strong for your kids. They do that. If they're a DV survivor, they're doing that all day, every day. I promise you, they're putting up with things that they wouldn't put up with if it was just them. Because they know it's one thing to know I might go hungry tomorrow. It's a whole other thing to think your kids might go hungry tomorrow. And people make choices based on that. So these are some things that don't help. So I promise we don't just give you the negative. The next slide is some things that are, and it's not just happy talk, because, oh, you're brave, I'm so glad you called, but giving people these subtle permissions and thanking them and recognizing that it takes some courage and some strength, because starting a conversation, and you guys are seeing it in your data, starting a conversation is often starting down a path to different types of interventions, and that takes a lot of guts. So acknowledging that goes a long, long way. So our next slide, just so you know a little bit more about our member programs, gives you a point in time. None of these numbers are really critically important, but our national organization picks a day every September. We do a point in time. This is one day in Ohio, what our programs are doing. How many people, you know, those hotline calls, 27 contacts an hour, that's 24/7, 365, the number of calls we see. We have programs with Chatline and web chat, and that's not even that. Text services, those kind of things. So that's just to give you a hot minute, the numbers that are out there and what folks are saying. So that's kind of the DV overview. And I'm going to take a couple minutes and explain some of the other resources we have. So the next slide is Ohio Heals. And this was a federal demonstration project linking systems of care. And Ohio was one of 4 states to receive this grant funding. And so our project was linking systems of care for Ohio's youth, LSCOI. That's not exactly an acronym that trips off the tongue. So if we go to the next slide, and that just gives you a little bit. It was Case Western Reserve did all the research for us. It was us, and it ran through the Attorney General's office. But then let's go to the next one. What we were trying to do is make sure no matter where children who'd been victimized popped up in a system, that they were identified, linked to resources, and that these systems were better coordinated. So the next slide gives you our website. So HEALS is also an acronym, helping everyone access link systems. A little less clunky than LSCOI, but the website, when you go there, what I want people to know is about LSCOI has got who all was involved. So our moms are proud, but nobody else in the universe really needs to look at that tab. There is a tab that you guys can use, the For Victims tab. Send it to let families know that it's there. And I'm going to actually, Brooke, get you some information, because we have flyers with a QR code that will take people to the website. Whatever resources we have specifically for parents who are working with kids who are victimized are there. There's a For Professionals tab with links to all sorts of research and training we did, other things. But the thing that I really want to tell people about is that resource directory. And the other thing I want to tell you about the website is that the web developers who put it together optimized it for mobile. In spite of the fact that we all spend a gazillion hours a day in front of laptop and other computer screens, more than 80% of all searches are actually done on phones. So this doesn't have any drop-down menus, because those don't convert well to mobile devices. It's all tiles. If you click it, it takes you directly in. We also know that when people search, most people, and your doctors, I'm a lawyer, we're all nerds. We'll go digging for stuff. Most people won't click more than 3 times. So it's laid out so that there's a lot of surface area. If people want something, they're just 2 or 3 clicks to get into what they need without having to drill down and understand anything. But let's hop to the next one. One of the things we have in the resource directory when you go there is there are a list of hotlines, chat lines, text lines, the Red Tree House, which is probably something, if you're SEEK trained, you're familiar with, the Ronald McDonald House website that has all sorts of resources. We looked for trauma counseling all over the state, And there is a database specifically that you link through the Ohio Heals website that will get you into the trauma counseling side of Red Tree House to make referrals for folks. Organizations in each community that help people meet their basic needs, crime victims, all those sorts of things are there, excuse me, in that resource directory. But the last thing on that list is the county resource guides. So pop over to the next page, or the slide, which is a little tutti frutti, because the resource guides, they have the county name, the county seat, and the census. Everything on the resource guides, there's 88 of them for 88 Ohio counties. But you click on the county and it takes you to the county webpage. You click on the county seat and it either takes you to the county seats page or the county's Wikipedia page. If you click on the population, it takes you to census data. There's a link below that to find your elected officials, which if you put in your address, you can find your state and federal officials based on that address, if that's useful to folks. And then there's a color-coded list. Every law enforcement agency in the county is listed with a link to their site if they have one. All the prosecutors' offices, the courts, and the legal aid programs that serve that community are there in a box. All the victim service programs, so if there's a rape crisis, if there's a CAC, if there's a DV program, if any other kind of freestanding, if there's a chapter of MAD, all of those are in a victim services box. There's a hospital medical systems box with links. There's a box with resources for kids and family. So your child welfare, if your county has a CASA program, different types of trauma counseling, ADAM board sorts of things are there. And then every school district in the county. And so you could print these things in theory and it would give you a list. But the point is, as a live document, if you're looking for Claremont County's whatever, you can go and not only do you see the list, if you click, you'll be right there on their page. So we want to make sure that people know those resource guides are there. And the link to all the resource guides, the drop-down box on the website is right under all the hotlines and chat lines. So we're hoping people will find that very, very useful. So let's hop up to the next one, because I know our time is getting short, but I promise you, we're on slide 22 out of 30. So we're getting there, folks. I promise. So let's go one more. Just to let you know a little bit about what we do. We do have, the CDC has funded child abuse prevention, DV prevention, and sexual violence prevention for a number of years. The DV prevention funding is called Delta, and it's been around for 21 years now. We just got funded it's a 5-year grant cycle usually, and they have different names. And the current one is Delta Ahead, which is addressing health equity, achieving health equity by addressing disparities. So we're looking at the social determinants of health and risk and protective factors. And there are DV specific risk and protective factors, just like there are things that work with ACEs. And we have a project and we're working with our program in Knox County. The state level work is around child support policy, like I was talking about before, in terms of how we make safe access. Child support is the #1 way to lift single parent families who are in poverty out of poverty. But families who've experienced DV don't seek it for all the reasons I talked about before. So we're trying to figure out how we can make the child support system safer for survivors so that we can lift more families, particularly more children, out of poverty. We do a lot of work around engaging men with the Ohio Men's Action Network. And the local program also knows, this is going to sound kind of strange, but you guys understand these sorts of things because when I talk to groups like the Rotary, they don't, but you'll have an appreciation. We know that the younger kids start drinking, the more likely they are going to either experience or perpetrate acts of violence. So when we survey communities through the ODH, through the youth behavior surveys, and we know that there's communities where the drinking age starts around 12 and a half, anything we can do to increase that drinking age decreases incidences of violence in the long run. So we're working on alcohol outlet density and server training and different things like that, so that we are moving the needle on the age of alcohol use onset, particularly in Knox County. But we have a prevention page on the ODVN website. So if that's something that's of interest, that's there. And if we go to the next slide, it gives you a little bit of an idea of what OMAN, that Ohio Men's Action Network, just like we talk about how children can't solve child abuse, DV gets looked at as if it is exclusively a women's issue. That is not true. There are definitely women who batter men. Battering occurs in same-sex relationships. It's not one-sided, but even if it was, you can't leave victims alone to solve the problem. We need to change some ways we deal with healthy masculinity and training around that. So that is a really quick overview of our prevention work. So if we hop ahead, and actually the last courageous conversation we did was around transgender, and how men react to folks who are transgender males, transgender females. And so that is online and available to watch. And it was a really, really interesting conversation, what it means to be to deal in a positive framework and working with folks. So let's hop to the next one. And what we work with when we do our legislative policy is we need to make sure we're getting money out to our programs. A big thing we work on, particularly on the policy side, is how are things going to reduce fatalities? Because the reality is the past 2 years, we've had 22 children in Ohio murdered as a result of domestic violence incidents. Either the offender intentionally shot the partner, the children, and oftentimes those become family annihilation cases where they shoot themselves, or most of these are actually all the family annihilation were gun-related deaths. But they kill themselves. And sometimes we've seen a fair number of people who are holding really young children, infants in their arms. And so the child dies of a gunshot wound because mom was getting shot and mom was holding the kid, or the kid ran to find out what was happening, and was killed. So we've been doing the fatality report for 8 years. And the past 2 years, we've seen the highest, both years were 22, and that was the highest number of child deaths we'd seen. So when we talk about enhancing child safety, that's actually usually on the civil side of the equation, and everything I talked about on the DR side, where we watch protectives' moms be accused of alienating the abuser. And they're not trying to alienate, not that alienation doesn't exist, but they're not trying to alienate, they're trying to keep the kids safe. And the protective steps they take to keep the child safe from someone who's abusive gets twisted into alienation, and the batterer gets custody instead. So one of the things, if we go to the next slide, we do an annual fatality report. We base it on the state fiscal year and release it every October because that's Domestic Violence Awareness Month. And that's available, and that link is in there on our website. So just so that if people want to take a look at where things are happening, and what it looks like, Franklin County far and away is the highest rate, and Franklin County is working on that through their health department and a couple other agencies, trying to figure out why their numbers are so far beyond everyone else's. Cleveland has got some specific fatality review things that they've implemented that seem to be making a difference. But that in the end is what we're trying to do, is stop incidences of fatal violence. So the last 2 slides I have, I told you we'd get there, is some list of services. We've got lots of information on traumatic brain injury. Well, like I said, we're working on funding for forensic exams. The thing to know about our services is we don't just pay for hotels or relocation or some of these things. We need to know that survivors are plugged into their local program. So it's really important to say, wherever area you're in, plug into your local program, because we know we can't do these things in isolation, that people need comprehensive support. And we at ODVN can't do that as the state level entity. The local program knows the local service providers. So we want to make sure that there are advocates there helping people see around some of those blind corners, because the advocates have experienced this with other people, and make sure people get comprehensive care. But we have a page on our website, on the ODVN website. So if you go to the last slide, that gives you some of the contact info. That's resources and reports. So the fatality reports, other reports, there's ways to get into local programs there, but this is us, and the top line is me. So that if people have questions or want to contact me, that's actually straight up my cell phone. Please feel free. I'm happy to answer anything that you've got, plug you into any resources, plug you into anybody else on our staff who can do things for you. So I apologize because I just talked your ears off. But if anybody does have any questions, I'm happy to answer them.
We do have a moment for questions. Lisa, thank you so much. This is very impactful information.
Thank you.
This is Dr. Cuevas. Can you hear me?
Yes, hello.
Hi, I have my conversation from my clinic in Metro Health with Brooke. And we, just to mention my experience, I work with Hispanic parents, and it's something like a bias maybe when I try to make the survey. I have this situation that for me is normal as well because I'm Hispanic. We have the idea that the family is very important for every kid, and the background from grandpa and the aunties and mom and dad. But where they are in the visit or the encounter, when I try to give the survey, mom used to share the questions with dad. And when we are addressing the topic on violence, I have two dads that get like mad when we are asking mom about violence because they are good dads, but they say why they are asking you that. I'm a good dad. Why are they? We have the idea that we are accusing the dad and not the mom, so we can have both scenarios. But in our culture with Hispanic dad, maybe parents they feel offended when we are talking about violence.
And we get the same thing. I used to run a child advocacy center, and I surveyed anybody who brought a kid in for DV because we know how often they go hand in glove. And occasionally we would get, why are you asking me this? Why do you think this? I don't think anything. We ask this of everybody because you never know. And if it's an issue and you could use some help, we want to be able to help you. But if it's not applicable to you, that's totally fine. But you didn't get singled out for this screening. This is what we do. So it's about, this is something. And so we got to the points where I was training the advocates that don't wait for them to ask a question and answer it. Say, we ask this of everybody. We just want to make sure we're being comprehensive and help you in every way possible. So that why did they give this to me? What about me makes them think this or think they need to do this? It's if they know this is the entire packet and we do this for everybody. We found that helpful.
Thank you.
Thank you for bringing that up, Dr. Cuevas. I know we talked about it. Okay. Yeah. Yes, thank you. Thank you everybody for joining today. And for those who are watching the recording, let me know if you have any questions. Lisa and I will be sending additional items out that we referenced in the program today and the presentation. Lisa, any last notes?
Just thank you very much. I very much appreciate what you do. Like I said, I was a CAC director. So I'm familiar with the SEEK program, and I just think it's fabulous. I'm so glad it's expanding.
Thank you. And thank you for your help today. Okay. Have a good week. Talk soon.